All right, let's dive into a fundamental challenge in clinical electrocardiology, figuring out the cause of a regular, narrow QRS tachycardia. Now, this is a super common scenario, but it demands a really rigorous and systematic approach to be certain about the diagnosis. And that's exactly the framework we're going to build together today. So, here's how we're going to break it all down. First, we'll lay out the basic problem, what I'm calling the tachycardia conundrum. Then, we'll define the four main possibilities. After that, we'll apply what we've learned to a couple of case studies, really focusing on P-wave shapes and that tricky atrial flutter. And finally, we'll wrap it all up into a neat diagnostic algorithm you can use. Okay, so let's set the scene. You're a clinician, and you're looking at an ECG with a regular tachycardia where the QRS is nice and narrow, less than 120 milliseconds. Right away, a specific list of possibilities should pop into your head. The real challenge, the fun part, is systematically digging through the subtle clues in that tracing to land on the correct diagnosis. So take a look at this. This is our index case. This 12-lead ECG shows that classic pattern, a fast, regular rhythm with narrow QRS complexes. But at first glance, well, the actual origin of the rhythm is a little ambiguous, isn't it? It's that ambiguity that means we can't just rely on pattern recognition, we need a meticulous, ordered analysis. So the big question on our minds is, what's really driving this thing? Is it just a normal physiologic response, sinus tachycardia? Or maybe it's coming from some rogue spot in the atria, an atrial tachycardia. Could it be a reentrant circuit, what we broadly call supraventricular tachycardia, or SVT? Or are we looking at the great mimic itself, atrial flutter with 2-to-1 conduction? To be certain, we've got to build a solid framework. Okay, to really tackle this, we first need to build our diagnostic toolkit. We're going to define the key, high-yield ECG criteria for each of those four main possibilities. Think of this framework as the foundation for everything else we're going to analyze. This table really boils it all down into specific, actionable criteria. For sinus tachycardia, you're looking for a very specific P wave that's diphasic, meaning it goes up then down in V1 and is completely positive in lead 2. For atrial tachycardia, you'll see a P wave before each QRS, but it won't have that classic sinus shape. With SVT, you often can't even see the P wave, or if you can, it's inverted. And finally, atrial flutter with a 2-to-1 block, that has a signature look, a continuous sloping baseline in the inferior leads with no flat isoelectric line at all. All right, theory is great, but let's see how this framework actually works in practice. We're going to start with a head-to-head comparison of two of the most common differentials. And the whole thing is going to hinge on analyzing the most important waveform for figuring out where a supraventricular rhythm is coming from, the P wave. So, let's go back to our first case and do a really detailed analysis. First, I want you to focus your attention on lead V1. See that little bit of atrial activity right before each QRS complex? Notice how it has that distinct biphasic shape, first positive, then negative. Now shift your eyes over to lead I. Here, the P wave is clearly positive and upright. And what do you know? Those findings are a perfect match for the criteria for a sinus origin. The diphasic P in V1 and the upright P in lead 2 confirm that the depolarization is starting in the sinoatrial node and traveling down and to the left like it's supposed to. So the diagnosis for this tracing is, without a doubt, sinus tachycardia. Okay, now let's switch gears and look at a second case. Again, we've got a regular, narrow, complex tachycardia. Let's use that same rigorous P wave analysis. We can definitely see some atrial activity before each QRS. But what's the key difference here? Take a close look at lead I.
See that? In this tracing, the atrial activity in lead 2 is completely negative. An inverted P wave like this is a huge clue. It tells us the atria are being activated in a retrograde fashion, from the bottom up. That finding definitively rules out a sinus origin and points us toward either an ectopic atrial tachycardia, starting low in the atria, or an AV junctional reentrant tachycardia.
And putting them side by side really drives the point home. It just beautifully illustrates the diagnostic power of looking closely at the P wave. On the left, you've got that classic sinus P wave. On the right, that non-sinus, retrograde P wave, which is the key to diagnosing SVT. It's a subtle difference, but it's everything.
All right, now we're going to level up the difficulty a bit and talk about atrial flutter. This rhythm is notorious for masquerading as other tachycardias. It's especially tricky when it conducts 2-to-1 to the ventricles, because that creates a perfectly regular rhythm right around 150 beats per minute.
And this is where a lot of people get tripped up. It's a common and critical diagnostic mistake. If you only look at one lead, say V1, it might look like there's just one P wave for every QRS, and that can easily lead you down the wrong path to a sinus tachycardia diagnosis. The real key to unmasking the flutter is to look at multiple leads. The pathognomonic finding, the real giveaway sign, isn't usually in the chest leads, it's in the inferior limb leads. The key is that there is no flat isoelectric baseline between the T wave and the next P wave. Instead, you get this continuous undulating waveform. And here it is. This rhythm strip from lead I2 is a perfect visual of that description. It's the classic sawtooth pattern. You see that continuous, uninterrupted sloping of the baseline. Each tooth of that saw is a flutter wave. One gets conducted and makes a QRS, but the next one is blocked and it's hiding in the T wave of the beat right before it. That is the definitive sign. So, to really get your suspicion up, there are a few other clues you can look for. First, meticulously check V1 or AVR and see if you can spot evidence of 2 atrial events for every 1 QRS. Also, if you calculate an atrial rate near 300 per minute, that's almost always atrial flutter. Once you have that suspicion, you have to go back to those inferior leads and actively hunt for that subtle yet diagnostic sawtooth pattern. Okay, so we've looked at the theory, we've gone through the cases. Now let's pull it all together into a practical step-by-step diagnostic algorithm that you can systematically apply to any regular narrow QRS tachycardia you encounter. So here it is, the final algorithm. Step 1, you check lead V1 for that diphasic P wave that suggests a sinus origin. Step 2, you confirm it with a completely positive P wave in lead 2. Now, if those sinus criteria aren't met or you're still suspicious, you move to step 3. You scrutinize those inferior leads, looking for the absence of an isoelectric baseline, the hallmark of flutter. And finally, step 4. You confirm suspected flutter by looking for that 2-to-1 activity in V1 or AVR. A structured approach like this makes sure nothing gets missed. And this really gets to the heart of what we're talking about today. Becoming an expert in ECGs isn't about memorizing a giant library of patterns. It's about consistently applying a rigorous, systematic, and physiologically sound method of analysis to every single tracing, every single time. So I'll leave you with one final thought to chew on. We've built a really solid framework for the 4 most common causes. But what else is out there? What about the less common rhythms or even technical artifacts that could perfectly mimic a regular narrow complex tachycardia? It's a question that reminds us that we always need to be vigilant and keep learning in the art and science of ECG interpretation.